afternoon, everyone. My presentation for today is comparing myopia control, defocus incorporated multiple segments, which is known as DIMS, versus atropine versus a combined approach. So as we all know, the prevalence of myopia is increasing year after year, and it is predicted that the prevalence of myopia will increase to up to 48% in the year 2050. There are various methods for slowing down the myopia progression. And the most commonly used is the low-dose atropine eye drop 0.01%, which acts on the sclera and inhibits the glycosaminoglycan production and therefore the eye growth. And the second and the recent one is the use of dim spectacles. It works on the principle of peripheral myopic defocus and simultaneous vision. It is a dual focus spectacle lens. There is a clear zone of 9 millimeters which corrects the distance refractive error, and there is an annulus in the mid peripheral area which comprises of several hundred circular segments in honeycomb pattern with a relative positive power of plus 3.5 diopters. So the aim of the study was to evaluate the efficacy of DIMS versus a low dose atropine versus a combined approach for myopia control. So this study was a non-randomized prospective controlled observational study which included 150 children in the age group of 8 to 18 years. Now all those children who had a myopia with a spherical equivalent refraction of between minus 0.5 to minus 4 diopters, astigmatism of less than 2.5, anisometropy of less than 1.25 diopters, and who were compliant with the therapy were all included in the study. And subjects who had undergone any previous myopia control therapy in the past or had a progression of less than 0.5 diopters SER in either eyes or had other eye diseases or suspected genetic syndromes were all excluded from the study. So all the children underwent a thorough eye examination which included the measurement of BCVA and spherical equivalent. All the patients underwent a slit lamp examination, dilated fundoscopy, and axial length measurement using an optical biometer. Now, these children were divided into 4 groups. Group 1 was a low-dose atropine group where 1 drop of low-dose atropine was instilled in each eye every night before sleeping. Group 2 were the patients who opted for DIMS glasses, and these patients were instructed to wear the glasses throughout the day. Group 3 was a combined group of DIMS glasses and atropine, which was used at night time. And group 4 were the patients who opted for or who continued wearing the routine spectacles and without using any therapy. Now parents were free to choose their preferred option or to continue with single vision glasses or the routine glasses, and follow-ups were done at 6, 12 and 24 months after initiating the therapy. Now these were the results. So age distribution among the 3 groups, there was no statistically age difference between the 4 groups. When we saw the baseline spherical equivalent diffraction, coincidentally again there was no difference, statistical difference between the 4 groups, and similar result was noted also in the axial length measurement at the baseline for the 4 groups. Now there were 2 primary variables which we studied in our study. The first one was the change in the SER or the spherical equivalent refraction measurement, which at 6 months interval for all the 4 groups didn't show much variation among the 4 groups, but at the end of 1 year and at the end of 2 years, obviously there was an increase in SCR in all the 4 groups, but the maximum increase in the SCR was, as seen in the graph, was seen in the control group who continued wearing the routine glasses, and it was almost about 1.5 diopter increase at the end of 2 years. And the minimal was seen in the group where the patients chose a combined therapy. Now similar findings were also noted in change in axial length measurement. At 6 months, there was not much significant difference among the 4 groups, but at the end of 2 years, the maximum increase in the axial length was seen in the control group, followed by the individual use of atropine and DIMS, followed by the minimal increase was seen in the combined group. So to conclude, individually low-dose atropine and DIMS glasses have similar efficacy, which helps in controlling myopia progression by around 50% in our study and also according to various literatures. However, combined therapy of atropine and DIMS has the best efficacy in controlling myopia progression, which was around 65 to 70% in our study. So the limitations, obviously the therapy becomes slightly expensive, and the use of AI-based tool to predict myopia progression was not used in our study. Now how do we translate this into our clinics? If you use an AI-based tool which is recently launched, this helps in better understanding of the myopia progression, and it gives you this kind of graphical representation which helps in convincing the parents better for which myopia control therapy to choose. Thank you.
My main concern is the randomization was not there here, and secondly, the choice is dependent to a great extent. A parent will never choose something, will not, if they can afford it, they'll take it.
Correct.
So the thing is that if they are more aware and they are better off financially, then the response and the follow-up and the confounding factors are very different in those groups. So you cannot really compare them so
But we couldn't randomize this study because of the same issue. The affordability is the main issue. So, but in a non-randomized,
the parents were more aware and more motivated.
Anyways, all the children who were included in our study, all the parents were equally counseled about the different
That was another
therapies.
thing. Did you have equal counseling as in one video which was constantly played, or there is a tendency to group, like, oh, I have less in this group, so
No,
or
not
some days
it was only
the
me.
counselling-
It was a one single person who counseled all the parents, and then the parents.
Even the counseling should have a
particular
format.
Yes, absolutely. There was
Those 8 points or 10 points.
Correct,
Then
correct.
it becomes replicable.
Correct,
So
correct.
if you are just saying ki I'm the same person, but the format of counseling also should be exactly the same.
It was same for all the patients.
What the range of myopia you suggested is?
0.5 to, in my study I included less than 4 diopters because we wanted to exclude the syndromic myopia and all those patients, which can affect the outcome of the study.
So higher errors you have included in the study?
Sorry?
Higher power.
More than -6.
More than -6. More
Less
than
than
4.
4 were included, more than 4 were not included.
Not included.
Not
sister.
included.
Not included.
Yeah.
sister.
Sometimes I think parent-to-parent counseling also helps a lot, especially with the long-term results.
Counseling is a major thing in this study because it was a non-randomized study.
Exactly.
Yes.
Counselor is one part,
Yes.
but one parent talking to another parent,
Correct.
that I think is a better way of doing a counseling.
Okay.
So what the cost factor you said, however?
Cost for the DIMS glasses was around 16 to 17,000.
You use
The
a
glasses.
single brand or a different brand?
Sorry, same brand.
Same brand.
Yes, Hoya. We used Hoya brand.
I think if once this gains a popularity, the cost will come down.
Yes,
It's
maybe.
a demand and supply.
Yes. True. Thank you.
Thank you.